Welcome to another edition of Food, Faith, and Feelings, brought to you as an educational program under the nonprofit Manna Scholarship Fund. Our program is designed to help you better understand issues related to your physical and mental diet, what you consume that is impacting your head, your heart, and your soul. We are thankful to our business partnership with Paradigm Security and Mr. Rick Strawn for providing this opportunity to come to you. We hope to enrich your lives as he has enriched ours. My guest today is the one, the only Madison Day Giles. Hello, Madison.
Hello, Genie. Dr. Burnett.
Yeah, I happen to be Madison's boss.
The best boss ever.
Thank you. Madison has come to Manna, I guess, starting in January of this year.
Coming up on a year. What?
Wow. And I brought Madison on today because she wears a couple of hats with Manna. One is that she is a licensed, she is an associate professional counselor through the state of Georgia. And so she does play a therapist at Manna, and she's a very good therapist. And then she also, because of her overwhelmingly bubbly personality that is like a social butterfly, extreme extraordinaire, she is also doing marketing for Manna. And so today, though, she has a very special niche, and I'm going to let her explain that. And so I would like to introduce everyone to Miss Madison and discuss that we are doing the spectrum disorder and eating disorders. So as we were talking with Mike earlier, Mike said, "What is a spectrum disorder?"
So, a spectrum disorder. So, most people, I think, have heard of the word autism, maybe Asperger's, something along those lines. Those are all spectrum disorders. So, in the eating disorder world, the one spectrum disorder that comes up often is called ARFID. It's an abbreviation that stands for Avoidant Restrictive Food Intake Disorder. And that also goes on the lines of like a spectrum disorder, which, simply put, is a neurological disorder that has to do with your senses. So a sensory overload can be something that you see. I don't know, do you have any other?
So for sensory, yes, the spectrum disorders commonly do have sensory integration disorder. And our brain has the capability, if it is a, quote, normal brain, it has the capability of inputting sensory information through your eyes, through your nose, through your mouth, through your skin, and it has the ability to sort of dumb down certain senses or heighten up, pull up certain sensory information. And so when someone has a sensory integration problem, they might have issues related to texture. So if someone's pants are scratchy, people with sensory integration disorder cannot tolerate that. Mm-hmm. So they would prefer to walk around naked or in their underwear as opposed to wearing a certain pair of pants. They just will not do them. Mm-hmm. This can also be sound. I actually had a client one time that the flushing of a toilet felt like it was like a huge thunderstorm to them. And it was really sensory, like it was overwhelming. Light, sound, texture in your mouth. Like, so sometimes clients have come in and they cannot tolerate mashed potatoes in their mouth.
Yogurt, cottage cheese.
Yeah, they feel like things are it's too much. Mm-hmm. So when that person's brain cannot filter out or segregate the different senses, then we call that a sensory integration problem. And that is very commonly, like we said, a part of the Asperger's autistic spectrum. So when you think about those types of individuals that have autistic, Asperger's sensory issues, what kinds of behaviors might we see, Madison?
So, well, in the food, so like we talked about food texture. So like a way that you could see someone that has like a spectrum disorder would probably be like they eat the same thing over and over. 5 chicken nuggets, mashed potatoes or mac and cheese. That's it. Every meal, every day. And then for like the textures, that same stuff. You might see that they wear the same outfits every single day, or the same shirt in different colors because it's that soft material. Behaviors could be, I've seen mute versions where they can't speak, where they just use actions, whether that be hand motions or noises. A lot of the times you see just a very, like, for example, like these lights, like fluorescent lights, you couldn't be in this. Someone with that would be probably in a sensory overload position, which would make them feel very uncomfortable. So they might be like hiding under like their hands or just like freaking out, maybe showing some anxiety attack symptoms, anxious feelings, just because of the light is too bright, because they see things so bright. Things are so loud. So like us talking to this microphone, that could be an overload for them because they hear it so much. And that's how it plays a part in the eating side, because you taste things, you feel things like to just a
differently,
really heightened way. Yeah, exactly.
Yeah. So just another aspect of people that have ARFID, well, not ARFID, well, ARFID, but also part of the spectrum disorder is they're typically, so if, especially people that are Asperger's, pretty intelligent. Mm-hmm. I have had a client in the past that would come in at 10 or 12 years old with a, 6-7 inch medical dictionary. And he was literally just reading it. Mm-hmm. They know everything. These are the kids that know everything about sharks. They know everything about dinosaurs. It's like once they figure out something that really jazzes them, they get into it in a very deep dive way.
That hyperfixation.
They could totally tell you everything, any nuances. So just to pull out a common reference, Sheldon.
That's what I was thinking about too.
Yeah, so Sheldon doesn't necessarily have that capability of connecting with the humanness of people. And so he really kind of comes across more like a computer and has this vast knowledge and a little bit arrogant and just really not being like, people actually are too complex and there's too much sensory information that are coming across from a human being. And so they typically will shut down and pull away from other human interaction. And another thing that I, when I saw a client, he was so rules driven. They're very, very like, they need structure. Because everything in their world feels really chaotic and big and overwhelming. And so they go into rules based living. And for example, one of my old clients, when he was a kid, his family went to a movie. And when the credits started rolling, the parents were like, okay, let's go. He was like, no, the movie's not over. So literally he made his family sit in the movie theater until the whole movie, including the credits, was over. And so they're very fun. They can be annoying and frustrating.
Just like anyone else.
Yes. And so sometimes logic doesn't necessarily apply. So we have to get really creative. So I feel like that's a really good explanation of what the spectrum disordered kind of person is like. And this, like, the reason it's called spectrum is because it goes from being really, really intense, like an autistic child that rocks and screams or doesn't do any, like they can't look at people, and so they're really introverted, all the way up to people that have the higher level is typically an Asperger's kind of a person, and even sometimes people that are Asperger's to normal, like, and they can function normally. So there's a huge variation in the type of person that we see that has this disorder. So great explanation. Now let's talk about them with eating disorders.
Yes.
So I have asked Madison because she really loves this type of person, this type of issue, and quite frequently when we are working with people at Manna Treatment, we will have some people, females and males, that will come in and they're a little bit different. They don't necessarily connect. They're not really socially driven. And so we tend to watch them and see what they can do. So we are trying always to put them in the most productive level of care for them. So sometimes they come in, and if we need them to do the PHP level of care. Tell us, Madison, what that might be like for them.
So
explain what PHP is first.
That's what I was thinking too. So PHP stands for partial hospitalization patient, or program. And that is our all-day program. So that goes from 1 p.m. until 7 p.m. And that would be our most intensive program that we offer. So let's say an ARFID, which again is avoidant restrictive food intake disorder, which I feel like is just not talked about in the eating disorder world or in the world in general. So if you have not heard of it, that is probably more common than if you have.
Right.
But how we work with it is, first we have to assess them to see if they could even handle program, because our program can be pretty full. There's a lot of kids in it, a lot of teenagers, a lot of young adults or whatever. So if we have, let's see, like a socially shy client, they might not be the best fit for our program. But if they have like ARFID as like a secondary and they like are struggling with other like anxiety, depression sides, then that's usually like, we're like, okay, yeah, you can do program because you need that extra social aspect. And we've seen it both ways. So typically it'll just start with getting to know the patient and understanding, okay, where did this start? Because sometimes it can start with like a trauma, people use food as punishments and rewards. And so if kids are being punished with food from a young age, it could make them terrified of, let's say, like mustard. First thing that came to me. And so they could all start right there. Like they're terrified of mustard, and then that could lead into other condiments. Now, no condiments are safe. So we start there, see what they're afraid of, see what they're comfortable with. And I always...
So I'm sorry, I'm going to stop you for just a
Go
second.
for it.
I know you're on a roll. But let's talk about the trauma with mustard.
Okay.
How can mustard be a trauma?
Oh my gosh, how can anything can be a trauma? So let's say you get sent home from school early because you did something and you got kicked out of school early. Let's say your mom is at home and she's like, you did what? So now you have to take spoiled milk and mustard shots. Yeah.
Ew.
Yeah, you have to drink 5 of them, and that's your punishment.
Who's going to do that?
Some people that are probably hurting themselves. Like, they're hurt in the inside, so they're hurting other people, that type of person.
Right. The other thing that could happen is that, let's say they had a sandwich and they had, I don't like brown mustard, but they had such a vile reaction to the brown mustard that they threw up.
Yeah.
So because of that taste aversion, because it was such a, like, horseradish can be such a nasty taste in your mouth.
Right.
I do not like horseradish. But it could be something that simple, maybe not as punitive as what Madison described,
Right.
but something that is as simple as having that as a condiment, or, you think that salt is sugar or sugar is salt, and you put that on your bread or on your food, and it becomes suddenly averse.
Right.
So that can be also, especially if someone has a sensory integration problem. If you put salt in where sugar should be,
Right.
It's going to be annoying and yuck. But for that type of a person, it could be like,
now they don't trust chicken tenders. Like, it could be detrimental.
Exactly.
Yeah, I agree, because it's like the negative association. So I think anyone can relate to this. Think of something that you got food poisoning from. We've all had it, and then the next day or the next 3 months, whatever, we're not eating that. Because we're like, ooh, that reminds me of when I threw up for 8 hours straight. And that's what happened to me with my ARFID. So I had pumpkin pie when I was little.
Whoa, what'd you just say?
With my ARFID.
So you had ARFID.
I had ARFID. Yeah. I always say, like, I was born with ARFID, but realistically it all started with pumpkin pie.
No.
Yeah.
Tell us your story.
Well, apparently I didn't know this until like later on because I was like, pumpkin pie's the devil. And then my mom was like, you know, you used to love pumpkin pie, right? And I was like, there's no way. Like, it's the worst. And she was like, well, that's because when you were little, you ate the entire pumpkin pie all by yourself and got food poisoning. And so I got sick off of something I loved, which is so classic because when I love something, I'm like, I gotta eat it every day. Which is ARFID, which can definitely be an ARFID thing. So, and then from then on, I was like, okay, I can't do pumpkin pie, which led to pumpkin smells, cinnamon, nutmeg, textures that are that creamy pumpkin pie. So at the time.
So you're not a pumpkin spice latte person.
Oh, nope. No.
Sorry, Bucks. It's not happening for Madison.
Nope, not for me.
Okay.
Yeah.
Well, all right. So let's talk a little bit more. Okay. So explain, if you don't mind, a little bit, because we didn't really cover the diagnosis of ARFID.
Mm-hmm.
I know it's avoidant. It's literally what it sounds like: avoidant and restrictive food intake disorder. So this could look like someone with anorexia,
right? Except the main difference is they probably like bread.
Right. The difference is they don't like. This is sort of the old food neophobia.
Mm-hmm. That was the old name. Yeah.
Food neophobia is the fear of having new foods. Mm-hmm. And so these kids typically like about 10 white, bland foods.
Yeah, we'll see our clients eating like pasta with butter, if even, maybe like Parmesan cheese. We see PB&Js or just peanut butter sandwiches. They eat the same basic, no flavored foods.
Yeah, they won't like, if you give them pizza, like they don't like colored foods, right? So no red, no green, no brown. And so if you give them a piece of pizza, they will scrape off everything and eat the bread. They like potatoes any way. They like rice, chicken tenders are especially the thing.
Yeah, sometimes meats are always questionable. I see a lot of clients that have an avoidance of meat because sometimes they have trauma, whether with like an injury. So I see that come up. Like if they have an injury, it's all of a sudden like, oh, now I can't eat red meat because that reminds me of that time I cut my arm open or something like that.
So interesting, different associations.
Definitely.
So, okay, now that we've explained a little bit more about ARFID, and now we know that you've had ARFID, so let us know about when you work with people with ARFID and with spectrum disorders. Tell us what it's like for you and for them.
Well, it's slow. I'll definitely say that. It's a lot slower than any other disorder that I've worked with personally because I feel like a lot of the time they come in a little reserved. My most recent ARFID client had never heard of ARFID. And that's terrifying. Coming in and being like, hey, I have this thing that no one else has ever been through. And me being like, hey, that's called ARFID. Like, you're not alone. It actually has a name. And they're like, what? Like, I was afraid of carrots. Like, you know, like they're afraid of all kinds of things. But it's a slow and steady because you don't want to intimidate them. You want to take it at their pace and you don't want to force things on it. Let's say like they come in for their first week of treatment and I'm like, okay, we're going to try lobster.
Not going to happen.
Not going to happen. I will say I definitely tried one time to have someone try a condiment, Chick-fil-A sauce. It's the best. I tried that a little too early for one and oof, it did not go well. It was like 3 more weeks until we could get her to try something else. So you definitely have to take it at their pace and I start with the things they're comfortable with. So if they're comfortable with chicken tenders, I'm like, okay, well, let's try chicken fingers and a sauce. Okay, you're comfortable with French fries? Okay, let's try potato, like sweet potato fries. And just doing things that are similar textures, similar feelings, similar smells even, and then opening them up to like, oh, that didn't make me sick. Oh, that didn't make me have a panic attack. And then you just expand your food horizons like little by little.
So folks, this is what we call exposure therapy.
Yes, desensitization.
Desensitization. That's right. It's not an easy word to say. So yes, exposing them and desensitizing them to the fear, which is I'm going to throw up, or I'm going to have a stomach ache, or I'm going to, I don't know, something else awful. This is how we work with them. And so most of the clients that we've actually had that have had ARFID, both males and females. We will put in our groups with the rest of our program clients that do not have this as a specialty or a disorder, and see what they can do. Sometimes we have to coax them. Sometimes smaller groups are better for them, like 2 or 3 people versus 6 to 8, because a lot of times people interaction can be overwhelming for them. And so what we will do is we will try and take them through as much of the program as we feel like they can handle. We determine if they are what they are getting, what they're gaining. And then once we feel like we've sort of reached their capacity in program, we will pull them out and we will have individual therapy with them. With Madison, we have a dietitian, and we also have people on staff that are nurses and have specialties in eating disorders.
Yeah, I feel like when you hear the word avoidant restrictive food intake disorder, that's like so close to what people would probably assume anorexia is.
Yep.
So I wanted to throw out the main thing, if you're sitting there oh, does my kid have this? They only eat chicken fingers. Because what part of it, some could be developmental, some if they're 4, they're probably gonna like chicken fingers a lot, right? So if you're sitting here does my kid have this? Does my child, maybe look at their body image, because the biggest thing that we see is with anorexia, bulimia, orthorexia, all of those, the body image, body dysmorphia. They struggle with that. With ARFID, that's definitely one of the most interesting parts about it. They don't care about their body. They're not trying to lose weight. It's the complete being, oh my God, I cannot touch this food. It's going to do something bad to me or whatever. So I just thought that I had to throw that part in there, that body image aspect is the only thing that's really not in ARFID that really distinguishes, okay, is this anorexia that we're dealing with or ARFID? And it can be both sometimes. They can always go intertwined with each other, so.
Yeah, I think at Manna, we typically do take the individualistic approach. We try and integrate everyone who needs our levels, the different levels of care that we provide. We will integrate them into the appropriate levels of care and work with them. If they can only take it, for 3 days a week, then we will try and work with them and their insurance to provide that level of care and that structure for them. We also, I'm just going to throw out our family IOP. For those of you that don't know, we started a family IOP in May of this year because I don't know if you know, but we've had a mental health crisis in this country, thanks to the pandemic. And so we couldn't put people in the highest levels of care, the residential, as well as, if they have medical issues, we send them to the hospital. But we couldn't get a lot of our clients into res, and they needed it. And so what we did was we created 2 different programs, our PHP Plus and our Family IOP. The PHP Plus is that in order to help people stop the acting out behaviors, we integrated a DBT specific group every single day. DBT is basically a coping skills program and process, and it's very, very highly structured and highly researched. And so we put those clients in DBT Plus. We also started our Family IOP, in which family members of the clients that are in the program that struggle with eating disorders are encouraged to come and attend, and we do 2 hours a day for 4 days. And what we have found is that when a client comes in and their parents join, or their spouse or their family members join, and any family, we allow any family member, grandparents, siblings, whomever, we want anybody that is willing to come and learn. And we put them in our program simultaneously. And what we found is clients went from, let's say PHP, our partial hospitalization, they went from 4 months or 6 months or sometimes even 12 months. And we found that the average person who was in PHP and they had a family member in the Family IOP went down to a month. Like it took them a month to go from PHP to the next level down, which was IOP. And the same thing happened in IOP. If clients were in IOP and their parents or their family members were in our family IOP, it dropped down to only a month. And it's just been incredible. So we are currently doing retrospective research. We're also including research. We are continuing. So now we actually have openings in our program. And so we are able to accept new clients right now and would love to help support you, whether your kid has anorexia, bulimia, ARFID, binge eating disorder. We treat them all. Ladies and gentlemen, if you are out there and you also have an eating disorder, we are more than willing to support you as well. So again, Madison, we're going to close for today.
Nice.
And it's been lovely having you.
This has been so much fun. I'm going to be like, Genie, I have another topic. Let's go.
Well, we do this twice a month here at Business RadioX with Mr. Mike Salmond. So I want to thank you so much for joining us today on Food, Faith, and Feelings. And this is presented by Paradigm Security Services and the Manna Fund. And don't forget that you can enjoy any of our episodes anytime by visiting businessradiox.com, selecting the Gwinnett Studio, and then clicking on Food, Faith, and Feelings. This program is also available on Apple iTunes, iHeartRadio, Spotify, or wherever you listen to your favorite podcasts. Until next time, I am Dr. Genie Burnett, and you've been listening to Food, Faith, and Feelings on Business Radio